So I'm going to talk today about translational research in developmental depression and suicide risk. And as a federal employee, I just need to say that I have no disclosures or any conflicts of interest. And I'd also like to thank the organizers for inviting me. Next slide. All right. I figured I would start with giving a brief overview of my talk. I'll talk about what translational research is, just to give you a sense of what type of research I'll be describing, a little bit about brain development, both in healthy development as well as how that development may become disordered and lead to mental health issues. I'll give a few statistics about depression and suicide in youth and across the lifespan, and a few snapshots of some ongoing research that NIMH has been funding and that we're really excited about. And then I may talk a little bit about how this relates to some of the other issues that we are talking about here today. Next. All right, so in a nutshell, the way translational research works is nicely illustrated by the division structure at the NIMH. When you think of health research or really basic science research, you may think of people in white lab coats sitting at benches and doing things with microscopes or pipettes or things like that. That's basic research, and that's really the idea of understanding the basic relationships between molecules and genes and what all is going on, how that relates to behavior, health. But in translational research, what we try to do is then use that information to understand how in humans we might be able to take that knowledge to inform our understanding of risk and resilience to things like mental illness, as well as possible ways that we could start thinking about treatments or preventions of those issues. And then finally, the end of the research pipeline would be to start implementing those treatments or ideas in the broader public so that everybody can make use of them. All right, as a very, very brief description of brain development, I can just tell you that brain development is extremely protracted. It goes on for probably much longer than you would expect. Essentially, what this picture is showing is that the rate of change of your brain is going on from birth, and it continues through age 20 and even beyond. And different areas of your brain develop at different rates, and the cognitive skills that are associated with those different areas also develop at different rates. And the ones that you see, those little spots of green at the 20-year-old level, those are the ones that are related to sort of cognitive control, being able to control emotions and things like that, which, as you may expect, is highly related with things like mental illness. And so disordered development, really anywhere along this developmental trajectory, can really have influences on downstream development that may lead to mental health issues. This is just a very brief picture of development in adolescence, a really crucial time for mental health issues and when they tend to develop. This picture basically describes adolescence as a period when the regions of your brain that are responsible for really primal drives, things like reward and fear and anger, those regions are developing a lot faster than the regions that are there to essentially control them, those frontal regions I pointed out. And the area in gray in between those two areas is what they call the risky period, which is when you can both act in a risky way, but also when you are at risk of disordered development really taking things in a bad direction. You can imagine that even if healthy development already shows this discrepancy between the drives that you have and the ability to control them, any deviation beyond these norms could really lead to consequences that may have serious mental health implications. Things like impulsivity, negative affect, decreased response to reward. These are all things that are associated with various mental health issues, and it's probably no surprise then that adolescence is the period of life that is most associated with the onset of mental health issues. So, what might be a contributor to disordered development of the brain? There are a ton of reasons why development can go wrong. There are a number of environmental stressors that can play a part, things like trauma, malnutrition, neglect, abuse, poverty, exposure to things in utero, either stressors, chemicals, all kinds of things. You can have a genetic predisposition towards disordered development, either a handful or a larger group of genes that may just make you more likely to develop abnormally towards psychopathology. There's many other factors, including your social environment, gender differences that different genders can be impacted by these things differently. The age at which some of these things happen to you can have differential effects. Where you are in your pubertal status with all these hormones going around and affecting things in your brain. And not only that, but all of these things have the potential to interact with each other. So things that may be bad may jump onto other things that may be bad and have a multiplier effect, or something good could cancel out something bad. So there's really a lot of things that can contribute to the development of the brain, either healthy or not healthy. And these are a lot of the things that we're really interested about in translational research. Okay, that's highlighted. So I'm going to highlight a few studies later on that deal with both some of these environmental stress issues as well as the social environment. But first, I want to just talk a little bit about some of the depression rates and suicide rates in the country, just to give you a sense of what we're talking about here. And these will all be slides that are data directly from our website, and I'll have a link to that at the end of this talk. As you can see, these are the ages of adolescents, so just between 12 and 17. And you can see in those dark blue bars, there's just a huge increase in the rate of depression over that time, from 5% to 17.4%. So really, I mean, when I say adolescence is a key time for the development of mental health issues, you're seeing it right there. And in fact, when we look at adults now in the dark blue bars, what we can see is that young adulthood is the highest rate of depression, and then it starts going down in middle and later age. Now, when we start looking at suicide, this is a chart of the leading causes of death. So this is just number of deaths and ranked by these different age bins. And what you can see is that it looks at first like a very similar pattern, right? It peaks around adolescence and early adulthood and then starts to drop off in later age. But in fact, when we look at the actual rates broken down by age and by gender, you can see that for males on the right, it's actually almost a linear increase across the lifespan, where the suicide rates just keep going up as you get older. And even for females, these rates increase through middle age and then start to decrease with older age. I really point this out to show that depression and suicide, while they're clearly related to each other, are different things, and they need to be thought of separately and can't just be lumped together necessarily. All right, so just a couple of studies that we're funding that really address these issues nicely and take a really interesting look at these. This study is called Psychobiological Mechanisms Underlying the Association Between Early Life Stress and Depression Across Adolescents. And early life stress is just what it sounds like. It's encountering some of these stressful life events early in life, usually preschool age or earlier. And we've known for a while that if you've experienced early life stress, you're at higher risk for later psychopathology. But it's still not entirely clear why this is. When do you have to experience this stress? What kind of stress leads to what kind of outcomes? And so we're really not clear on what's going on there. And so this study is attempting to parse some of those things out by collecting a large group of kids starting around 9 years old and just collecting as much information as they can about these individual experiences of early life stress. Very detailed. What types of stressors did they experience? When? How did they feel about it? And then just follow these kids over the years and do repeated assessments on them to see how their behavior was. They did several brain scans on these kids to see how their brain changes. How do their depression severity scales rate as some of them tend to develop depression in these ages. It will separately look at different parts of depression, just like it looks at different ways that you can experience early life stress, to really tease apart what leads to what contributes to problems where. And this is a really novel study that is hopefully going to really start cracking some of these nuts that we've been having trouble with. Another study that I'd like to highlight is biomarkers, social and affective predictors of suicidal thoughts and behaviors in adolescents. And this study looks at another phenomenon that we've known about for a while, but haven't been able to get into too deeply, which is that individuals who've been hospitalized for suicidal thoughts and behaviors are highly likely to make a suicide attempt within 6 months of discharge. Once you've been at a level where you've been hospitalized, you're now at a very high risk for fairly short-term recurrence of these thoughts and behaviors. And so they are interested in the family context that individuals are being discharged into to understand whether stressful environments may be particularly conducive to or maladaptive to fixing these suicidal thoughts and behaviors. And they're also going to look at whether early maltreatment may exacerbate the effect to which one's environment contributes to their either recovery or worsening situation. All right, I'm going to skip this slide in the interest of time and just show one quick map that I thought was very interesting. This is showing the rates of suicide across the United States on the left and the rates of opioid prescriptions by county on the right. And I just wanted to point out the similarities in the overall structure of these maps and how you can see a lot of regional similarities and overlap between these two factors. I'm not suggesting that one leads to another, but rather that there may be a lot of similar underlying causes that may be contributing both to suicidality and suicide thoughts as well as to opioids and drug use issues that we're talking about today. Here is a link to some references from what I talked about, and I'd like to thank you for your time.